Hi, welcome to DTV. My name is Millie Hughes. I'm an education outreach liaison at Doylestown Hospital. Joining me today is Teddy Dowse. Teddy is a nurse practitioner and our diabetes education coordinator. Hi, Teddy. How are you?
Hi, Millie. Thank you for that warm welcome.
You're welcome. Thanks for being with us today.
Thank you
Can
for
you,
having me.
yeah, can you tell us a little bit about yourself, what you do, how long you've been in this field, things like that?
So, I'm a nurse practitioner. I've been in the field of diabetes management and coordination for the last a little over a year. I joined the hospital last year in March. Prior to that, I came from Abington, where I was working as a hospitalist nurse practitioner.
That's great. We're happy to have you at the hospital.
Thank you.
So, what is your official role at the hospital and what does that really entail?
So my official role is as a to coordinate all aspects of diabetes care for our patients, and that what that really entails is my role is a two-part. It's seeing patients on the inpatient side and the outpatient side in the office, and so most of the days I'll come in and see patients that have been consulted to assess in the hospital, and I will see them for whatever need that may be, whether for diabetes management to get them started on diabetes medications or to educate them about their diabetes and self-management at home. And my role in the hospital, I mean, in the office, is to also see patients for diabetes education needs, whether be it for management at home or nutrition counseling. And that's pretty much what that entails.
So, you have some busy days.
Yes, absolutely.
Can you give us a short background just on what diabetes is?
Sure. And for some of you who are following, so I have this laid out on the slide. Diabetes is a chronic systemic disorder that results from a variety of hereditary and environmental factors that are typically classified or characterized by an absolute lack of insulin, inability of the body to use insulin, a decrease in insulin production, and or a decrease in insulin sensitivity. The resulting factor from all of that cascade is abnormality of carbohydrates, protein, and fat metabolism.
Okay, so you mentioned a couple different characterizations. I think most people are probably most familiar with characterizations that fit into either type 1 or type 2 diabetes. Can you tell us what the difference is between those two?
Sure. So first, I'll give us the statistics and the data on diabetes. Currently, it's 37.3 million Americans have diabetes. Of the 37, 28.7 million Americans have been diagnosed. However, 8.5 of them are unaware that they have diabetes, and 26.5 of those are older population that are 65 or older. Of that population that are diagnosed, 1.2 million Americans are currently residing in Pennsylvania with diabetes. So on average, every one person to 10 adults has diabetes, okay? That's 20 years or older. With that, also, we have some what we call pre-diabetes, and that's the people that are right before the diagnosis of full, that are quite meeting the criteria of diabetes, and that's 96 million Americans have pre-diabetes. So
There's a lot of people living with this condition.
absolutely. And so to break down the types, we really need to know what leads people to being either type 1 or type 2. And I'll give a little background about the pathophysiology. So insulin is the primary hormone that really facilitates the entry of glucose into the cells. It also facilitates glucose, fat, and protein storage into the cells, and it decreases glucose synthesis. That's the production and storage of insulin into the cells in the liver. It also decreases the breakdown of glycogen. That's another form of glucose, fat, and protein. And so in order to get to type 1 or type 2, we do need to detect it, or we do need some type of workup. Typically for normal fasting glucose, if a person had a normal fasting blood workup and their blood sugar is less than 99, they are considered not diabetic, or that's a normal glucose. However, the diagnostic criteria to be diagnosed with diabetes is a fasting glucose over 126, An A1C, that is really just the hormone. It's an enzyme in the body. It's a mature hemoglobin that has a glucose molecule attached to it for the duration of that hemoglobin. And that usually takes 90 days. So the normal number is less than 6.5. And in order for if we want to meet the criteria of diabetes, the A1C has to be over 6.5. So with the two combined, they meet the true diagnosis of diabetes. And so some of the symptoms, actually, in some cases, there could be also a random glucose check. If, let's say, someone presented to the doctor's office, they give them a script for blood work, they went to LabCorp, they had blood work done, and that showed a glucose of 200, and or the doctor's office did a blood glucose check in the office, and that was over 200. With that combined with symptoms and or an A1C of 6.5 or greater, that's a true diagnosis of diabetes. So some of the symptoms in non-pregnant adults are frequent urination, thirst, fatigue, unexplained weight loss. Okay. Some of the risk factors for diabetes are hereditary, obesity, and that's mainly for type 2 diabetes for people who are really lacking some exercise, race, age, stress, and by stress we mean either chronic illness or acute illness, and drugs. We don't mean street drugs, but more so drugs that do affect your blood glucose levels, like steroids, environment, endocrine disease, and that could be any type of thyroid disorder, and gestational diabetes. So now we're going to get into type 1 and type 2 diabetes. So the two types that are so common are type 1 and type 2, but there is also what we know gestational diabetes that applies to pregnant moms. So type 1 is any age, usually less than 30. Majority of them are less than 20, mainly preteen, teenage age. These patients present with a lean stature. They may complain of recent significant weight loss. They may also report extreme thirst and frequent urination. What's happening in this type of diabetes is, so this slide just shows us what's happening in the body before any type of diabetes, whether type 1 or type 2. So we eat a meal and digestion starts, and once metabolism starts, we then get what we call sugar, which is glucose. So in order for that sugar to get into the bloodstream, it needs a key, and insulin is the key that's going to get that glucose into the bloodstream. And as you can see, it's opening, the key is opening, insulin is opening the entry of glucose into the cell. So we can use it for energy. Now, with type 2, these types of patients are predominantly insulin resistant. They may have decrease in insulin secretion. Their body is still producing insulin, but they're just not making enough. They're usually 30 years or older. They may be overweight, and in some cases may not even have any symptoms at all. So back to the deficiency of insulin, what really breaks down what happens with type 1 or type 2 diabetes on a cellular level. So the blood, you're now eating, we have glucose floating around in the bloodstream. It's really not getting into the cells because there's lack of that insulin. As you can see, the key is canceled out. So no insulin is coming in at all. And this is applicable also for type 1 diabetes. So blood sugar is just extremely high in the bloodstream because, again, no insulin to get it into the cells. What ends up happening is in type 1, if they have absolute lack of insulin, they do require that insulin through the injection or through the IV to get that blood sugar out of their bloodstream into the cells. And the same thing happens with type 2, that we need to get that blood sugar out of the bloodstream into the cells so these people can have energy to carry on their day. So the road to type 2 diabetes, we did go through the diagnostic criteria. The bottom, which is green, is really those patients that don't have to worry about being diabetic at all. Their fasting glucose is less than 99. Their random blood glucose, either after a meal or any time, is 140 or below, and their A1C is 5.7 or below. Prediabetes is that, as I explained earlier, that stage where someone is quite not, they have no symptoms, but they're not diabetic yet. Their A1C is starting to go up, so it's between 5.7 and 6.4. Their fasting glucose is now over the norm. It could be between 100 to 125, and also their random blood glucose is anywhere between 140 and 99. Now, for true type 2 diabetes, they definitely have an elevated A1C over 6.5. Their fasting blood glucose, this is of the blood work that was done, is greater than 126, and their random blood glucose is 200 or higher. In type 2 diabetes, they are making some insulin. The body is just, there's too high of a need that the body is just not making enough. So some of the sugar is getting pulled out of the bloodstream by the little insulin that their body is making and putting it into their cells. But it's just not, the insulin is just not enough to capture every glucose molecule and put it into the cells. And so what ends up happening is they have more or residual elevated levels left over in their bloodstream.
Wow, so you help people with all types of diabetes, like we just saw type 1, type 2, gestational. What are the types of disease management, I guess, modifications or education are you giving your patients?
So when the patients have been diagnosed and they come to us, whether through a referral from their family doctor or we encountered them in the hospital and they were diabetic, we managed them, they will come to the office for what we call a consultation to try and find ways to manage their diabetes at home. That initial visit usually involves us sitting down, coming up with the plan, and that plan involves lifestyle modification. It may involve getting them on a medication or maybe not, but majority of it is really talking about physical exercise, their diet, getting them on a meal plan and a healthy diet, and also getting them to monitor their blood sugars. And if they have any weight loss issues, talk about what that implies in regards to weight loss and managing their blood sugars at home. Again, part of that initial visit is really to just come up with a strategy for them to manage their disease at home. And so the education initially that we will talk about is having them understand diabetes. We discuss nutrition components. We also educate them on what the impact of exercise is. And like I said, we will talk about medications, whether be it oral medications or insulin. And then we talk about support, because family support is a huge, huge implication when it comes to managing diabetes adequately at home.
So the visits in your office or even with someone who's in the hospital are really multifaceted and unique to each patient. I'm sure no visit is the same as the next.
Correct.
And so you mentioned family being such a big support. Are there support groups for patients and or their families? And if so, where can an individual find information about those?
Yes. So our education program offers both diabetes support groups for adults and also insulin pump support, because we do have a good population of patients in the community that are utilizing the insulin pumps. And we do encourage both our patients and their family members to attend the support groups. They're really just, it's an open discussion, exchange of ideas and ways that some people are managing or what it is that they're lacking or struggling with at home. And so our support groups are carried out throughout the year. The adult support group is every 2 months, and that information can be found right off of the main website of the hospital, the Doylestown Health webpage. And on that, they just have to click on services. When they click on services, it brings them down to alphabetical services that are offered by the hospital. They click on diabetes, and on that main page it talks about our support group, the dates of the support groups, and we specify the adult and the insulin support group. So that information can be found right off of the website. And for most patients, if they can't find it and they're having a hard time navigating the site, they can just call us directly at 215-345-2168. We're so glad to give them all the information that they need. The only requirement is that if patients, show interest in joining the support group, we do ask them to provide some type of information to contact them, whether be it an email, because we do need their permission to continue sending them the newsletters and information regarding our support groups. But they can find all of that on the website.
Great. And that's where a patient would go also if they want one-on-one nutrition or diabetes counseling with someone in your office as well?
So if they need nutrition counseling, they have to call the main office, and then we can get them triaged through, because we have 3 registered dietitians, and they each have a specialty. We have one who manages weight loss. We have one who focuses more on eating disorders and people that have food allergies and things of that nature. And then we have one who overall will talk about, people who are struggling with counting their carbs or really are wanting to get on the insulin pump, but they do lack that information, so they can sit down with a one-on-one nutritionist. And it's an hour visit, but they cover a variety of needs for these patients. And then if the patient is interested in diabetes education, self-management at home, that is a 2-way process. So it's our education program that they're interested in. And it's a 5-week program that we offer throughout the year. Now, mind you, our program is accredited and approved by the ADA. In fact, we recently had an audit, and we outperformed all the centers in Pennsylvania. But we do ask that the patients go on the website, again, the Doylestown Health webpage. They click on services, diabetes, register, and there's online intake forms that they fill out. Once they've completed filling out those forms, they then call our office. We make them an appointment. We bring them in. We sit down with them and really come up with an individualized plan, because part of it is really talking about their goals. Not everyone's goals are, the other patient's goals may not mirror the other person. So we really just focus on that individual, come up with their goals, teach them ways to monitor and how to really stay healthy and continue being successful in their journey. We also talk about the acute complications of diabetes and chronic complications. So we do cover a lot during that visit. Once they've registered and we've gotten a bit of information from them, they then can start the 5-week program. At the end of that 5-week program, we do follow up with them with a phone call. We also require that they get an A1C obtained by their family doctor, because that gives us real data in where were they at the beginning of the program and where are they currently at the end. We also have a Keep on Track class that we offer 6 months after they've gone through our education program. And it's really to just, again, refresh their knowledge and revise and review all the tools that we give them during the education program to make sure that they continue to be successful.
That's great. There's so much to know about diabetes, and I'm sure that patients and their families are thankful to know that there's so many services available to them. So thank you so much for sharing all of your information, for sharing what you do at the hospital, and for doing it. We're glad that you could join us today on DTV.
Thank you. Thank you so much for having me. It was wonderful.
Thanks. Thanks for watching DTV.